You're going to get excited? Yeah, she's excited. And do you know why she's excited? Athena, why are you excited? Because we're talking about the largest organ system in the body. Whoop, whoop. We're going to go into integumentary system. It's going to be fantabulous. You know why? Because it's 28 slides, that's why. And it's going to be a fast go through, which is exciting for all of us. So let's get in where we fit in, and that's inside our skin. Ooh, snap. We just did that. High five. Did you get it? It was a joke about Turger. All right, let's do this. 1, 2, 3, go. All right, so here is your structure of your skin. You have your epidermis, your dermis, and then your subcutaneous tissue. Now, the epidermis contains no blood or lymphatic vessels. It's nourished by simple diffusion from underlying dermal papillae. And what that basically means is diffusion is the spreading about of things for redistribution. You have your melanocytes, which produce melanin, melanin, see the Latin, which colors the skin. And then you have the exceptional epidermal regions like the conjunctiva and the lips. The epidermis is so thin, it's transparent. And then your lips, the epidermis is very thin and highly vascular, which is why we have that red shade, and why when we're deoxygenated, that goes from red to like white to blue. Sometimes it can get gray depending on what's going on, and that is because it's so vascular. That's why it's a good way to do capillary reflex to find out if someone is properly oxygenated or deoxygenated. Your dermis is like the vascular fabric of collagen and elastic fibers, which are woven in for like strength and flexibility. It contains the abundant touch receptors, which is really important because, when we get rained on, we go, oh man, that sure is cold. And then we try to make sure that our hair doesn't get soaked, and then we are dumb and run in the rain, which is something I would never encourage you to do. I would just get with the fact that you're going to get a couple of drops on you and be happy with that versus, falling and breaking something, and then we got bigger issues. The dermis also provides fingerprint patterns that is obviously your unique arrangement that makes you and is a way of showing who you are versus showing who someone else is. So when I think of bank robbers, they're like, I'm going to use sulfuric acid and burn my skin or fingerprints. And they talk about the CIA doing that and all the other things. And I'm going to tell you here, guys, that as fun as that story is, I can assure you that that is a myth. Because if I were to physically put sulfuric acid on my fingers, first off, it'll burn and then burn some more and then burn deeper. And putting water on it actually increases the catalyst that creates the reaction of your skin burning. So that's not a thing. Because if it goes down to the dermis, then it's not coming, like things aren't spending a lot of time to treat itself and to heal itself. So as much as I'd love to think that that's a cool thing that people do, sorry guys, I hate to be the bearer of bad news, but it's not going to happen. Your skin and the dermis is stretched beyond certain limits when you're dealing with pregnancy or massive weight gain or weight loss, which is why you get the stretch marks or the striae. It's called a stria gravidarium, if I'm not mistaken. It's gravidar. DARUM if you want to look it up. And it basically is the tissue repair or the attempt of tissue repair that creates those scars. So you'll see the stretch mark scars sometimes on really thin people and go, why did you have stretch marks? You've never been big a day in your life. And sometimes it's because when you're dealing with certain people who are really tall people, they will have a growth factor in their adolescence that will produce these. Sometimes if you have a boxer, you have to lose sometimes 40, 50 pounds within 6 weeks. Been there, done that, got the t-shirt. Like I said, it's a size large. It happens all the time. And sometimes, you got to lose 16 pounds overnight so that you can weigh in and be appropriate so that, you can have your sanctioned fight and you do the things that you want to do. So this is why we'll see this striated area and just know that they're stretch marks and just understand why it's doing what it's doing. You got your glands. You have your sweat glands, which open in the pores that secrete the clear fluid. This is for temperature regulation. So if we get too hot, we sweat more, duh. And if we get cold, we tighten that up so that we can retain that heat. Those are in your I believe it's eccrine glands. It's ECCRINE versus your apocrine glands, which are your sweat glands that are found in the armpit, the mammillary, or the mammillary area and the genital area as well. Um, so the apocrine glands are sweat glands, sure, but they're more than anything, they're scent glands. So that's kind of how I want you to look at that. So that, you have stinky pits and, you have your area, your mammalia area, that also excretes, breast milk, which is going to have a smell to it, obviously. And then, of course, the genital area, we don't need to get into that. We understand where that's coming from. Your ceruminous glands or wax glands in the external auditory canal. You've got your sebaceous glands, which are like your small sac-like glands that is lacking innervation. They usually form close to the hair follicle and produce an opening into the upper portion of the hair follicle. And its whole purpose is, again, to create a barrier. Since there is a physical hole or a pore, its job is to create a barrier so that nothing can penetrate it from the inside. This is an exit-only kind of situation. You got your mammary glands. Of course, we have milk-secreting glands. Those are the alveolar glands. It depends on the full extent of the pregnancy, to be quite fair. Sometimes pregnancies that don't last as long because things go awry, those will close up, and obviously they'll stay open longer if mom is breastfeeding. So your hair, there's about the same number of follicles in males than in females, which is kind of funny, right? Because you always think males have more hair, but they don't. Hormones that stimulate the differential growth for males versus females. Hormones, obviously, estrogen, testosterone, which is why you see people who are in transition that go on HRT or hormone replacement therapy so that they can get this stimulating hormone to have facial hair if they are female to male, and to lose that facial hair if they are the inverse. You have erector pili, which are smooth muscles that attach at one end of the connective sheath. That's in the middle of the hair follicle and at the other end of the dermal papillary region of the dermis. And on contraction, it produces what's called goosebumps. So that's kind of the structure and function. There's a lot more in between, but I don't feel like we need to play med school right now. That's a little bit much. But just as a recap of all the things that we missed in patho or we might have forgotten about, that's kind of how that works. So I'll go ahead and finish off this slide and we'll move on to the next one. Okay, here we're going to go just a little bit deeper. So, of course, you have your epidermis, which, if you go back to the last slide, was at the very top. Your keratinocytes, those are about 90% of the cells there. They originate in the deepest layer of the epidermis, and then the stratum basale, and then move up to the final layer of the skin, which is the stratum corneum. And also, they represent the major cell type of the epidermis, which is the outermost layer of the skin. So that's all you really need to know. Your melanocytes, we talked about earlier, produce your melanin, which dictates the color of your skin. Langerhorn cells, they are unique to a population of tissue-resident macrophages that form a network across the epidermis of the skin. And lots of words. Can we go ahead and clarify? Okay, cool. So the cells determine the appropriate adaptive immune response. Remember how we talked about the macrophages and how their job is to basically be these sentinels that fight against things to help you with your immunity. So that's how I want you to think of the Langerhans cells, is it's the guys that carry the soldiers, basically. And then, of course, you have your Merkel cells, and your Merkel cells are like a special type of cell that's found right below the epidermis, and its job is basically to tell the cells that you're feeling something. So these are your nerve ending receptors that receive the sensation of touch, may be involved in touch itself. And they also contain substances that may act as hormones to send signals to the brain to say, ouch, that sucks. So those are the Merkel cells. And I think of this when I think of the Marvel comic Deadpool, right? And he always talked about being a merc, and his job was to hurt people. So Merkel cells, pain. Merkel cells, sensation. See how that works? So if you ever get stuck, that's the easy way to remember it. And then you have your basement membrane zone. And your basement membrane zone is in the skin. It's kind of a critical interface between the epidermis and the dermis. It's a highly specialized structure, and it basically allows for communication between one and the other. So that way it can transmute information. So recalling back 2 slides, the dermis is below the epidermis. Epi means above. Dermis is skin, so above the skin. Dermis is the secondary layer, and then you have your papillary layers and your reticular layers. Now, your papillary layer is the thin top layer of the dermis, or the inner layer of the skin. The papillary dermis has connective tissue, has blood vessels that gives nutrients to the epidermis, which is above it, and that helps control the temperature of the skin. Whereas the reticular layer of the dermis has blood vessels that connect tissue that supports the skin. So hair follicles, oil and sweat glands, and other structures that are also found in the reticular dermis. Of course, subcutaneous tissue is next. And then your skin appendages like your hair, your nails, and your sweat and sebaceous glands, because any appendage is something that comes above or in a third dimensional view, right? So like hair comes out of the epidermal layer, just like nails come out of the epidural layer of the fingers and the toes, and sweat and sebaceous glands. So in your axilla, for instance, you've got your skin, and then you got your pores just subset above that so that you can secrete things that you need to, like sweat for temperature regulation. Okay, so nail conditions, they're not just aesthetic concerns normally. They could also mean that there are changes that can be a clue to an underlying systemic disease or infection. And I know most people don't really pay attention to nails, but in the case of assessment, especially in primary care, if that's your intention later in life, you're going to run into a lot of these problems. Prime example, usually ladies come in and they've got these really nasty yellow nails, and most people would say, oh, no big deal. Do you smoke? Well, yeah, I smoke. Okay, well, cool. That's the reason you have yellow nails, because you're smoking. Wrong. All right, what do you do for a living? Well, I'm a secretary. Okay, cool. Nothing there that sounds disruptive. What are your hobbies? Well, I like to garden. Ding, ding, ding. Okay, cool. So let's backtrack. Whenever you have yellow nails and you have a gardener, there are certain fungal conditions that you can get from the dirt, especially if there's cats, right? So you can get ringworm in your nails. You can get a fungi infection in your nails that need a specific type of topical ointment to kill it. Club fingernails are usually indicative of people who have COPD, and that's because it changes the cellular dynamic of that tissue of that nail, to accommodate for the fact that it is deoxygenated. So you have to keep an eye on these things. It's essential for every medical visit to find if these nails are having any issues. Common ones are brittle nail syndrome. That's when they just kind of pop off in layers, usually at the nail plate or above. You have the hard ones that are like onychomycosis, parenchyma, nail psoriasis, longitudinal melanochyma, Bowes lines, et cetera, et cetera. So these could be infectious problems, inflammatory problems. In some cases, these are neoplastic issues that let us know that cancer is abundant within the body system. And it's kind of a big deal. So we're not going to get into it this much because, again, this is MedSurg 1. MedSurg 2, you are going to get more in depth with it. So that's why I'm bringing the nails up, because you'd be surprised at how often you'll find that you have an underlying issue with the patient just off of looking at their hands. And then going back to sebaceous glands, we have your sweat glands. Your apocrine glands are more of a smell sweat gland, whereas your acrine, and I did look that up because I was like, acrine, potato, right? Just call it what you want, but the acrine gland is just the traditional sweat gland for temperature regulation. So we talked about this already when we were looking at the cell structure slide. Functions of the integumentary system: protection, barrier from bacteria and viruses, insulation, sensory perception, control of heat regulation, synthesis of vitamin D, and healing. There are a lot of things that the skin does that is unique to making sure that we are protected and we are provided a barrier so that all of the structures internally are kept protected. All right, so gerontologic considerations for the integumentary system. First and foremost, as you get older, your subcutaneous fat is lost from the hypodermis during the aging process, and it decreases the padding and increases the risk of hypothermia. It increases the risk for having skin breakdown because there's less inflammation. There's less there. You got less layers, right? You're constantly shedding them. Decreased subcutaneous tissue also increases the risk of pressure injuries on certain pressure points abound in the body, like the buttocks, the hips. If you have kyphosis, obviously, your spinal column, in the thoracic area, also sometimes up above that as well, depending on how deep, if you've had any mechanical surgeries. I want to keep one other thing into consideration too that you probably won't think about until you kind of get into the nursing realm. A lot of times people will have surgical hardware that over time, as you age, starts popping out, and it's not because it's sifting itself out and shifting out. It's because you're losing the layer that's kind of the middle layer is what kind of goes first. So a prime example is I have a friend that is a professional skier, and he always hates me talking about snowboarders because one day he was going down a slope and a snowboarder ran into him and he shattered his collarbone in 3 places. Well, no big deal, right? You put it back together, you put a couple of pins and screws in, works like new, no problem. Well, guess what? Now he's in his mid-40s, and now it is shifting towards the surface area. So now he has to be seen again because all of this hardware that he had in his collarbone that's been fine because of this deterioration of tissue through the aging process is now migrating out and is now poking through the surface of his epidermis. So he physically can't lay on his left side because guess what happens? It will poke out from the inside out, and eventually it's going to break open if he doesn't get it fixed. So you got to keep this in mind when you're talking about patient history, because if they are older and they are complaining of pain, it might not be because they have a bad hip. It might be because they're not telling you 20 years ago they fell on a patch of ice, had to have a hip replacement, and that hardware is going bad because he's losing that tissue and it's migrating out. So keep that in mind because it happens more often than you'd think. Decreased subcutaneous tissue also increases the risk of, like I said, buttocks and hips. The absorption of topical medication administered to a geriatric client can change due to decreasing subcutaneous tissue. So you also have to watch out for that. And I'm talking about the tissues that will affect how our body system works. So like your corticosteroids, sometimes if you do too thick of a layer, that's going to cause problems. Voltaren gel. Voltaren gel is a topical ointment that is reminiscent of your Icy Hot. It has a lot of pain relieving properties and also is a medicated ointment that contains sometimes a aspirin or Tylenol derivative. It's good for anti-inflammatory sometimes, depending on what type of gel you're using. And you got to be really careful with that too, because if you put too much on it, obviously it's going to burn like the dickens because it does have a little bit of a heat component in it. So you have to keep these into consideration. When your patient says, just give me some Icy Hot, and they're in their 60s and they haven't used it in a while, it's absolutely going to burn because it penetrates even deeper because it's expecting to have that layer of skin, but it doesn't. So, okay. So let's do a question. When examining the skin of an 80-year-old patient, the presence of which lesion will be of most concern to the nurse? Okay, this is one that you will find on your NCLEX, find on an examination like your HESI. And I'm going to be honest with you, a lot of people don't know what a lot of these things mean, and that's fine. Here's where I always complain about knowing your Latin comes into play. So watch this. All right, varicosities. All right, so I know what a varicosity is. I know what all these things are, but if you're brand new in the game, I want you to look at varix, V-A-R-I-C or V-A-R-I-X in this case for Latin, because varix means twisted, okay? And then viscosities basically means something in the vascular system or venous system. So varicose vein is what it comes up to. It literally means twisted vein that's raised, which are very painful, but pretty normal in the aging process. So I'm not going to pick that as my answer. Cherry angiomas. So cherry being red as the color. Angio means blood or lymph vessels, and then oma basically means a compilation of raised skin. So it literally means raised red area, which is a normal finding in an 80-year-old patient. Let's see, seborrheic. So think of sabor or sebum. Sebum is oil, and keratosis is just a raised area that is a senile process or aging process. So this literally means oil of the skin and wart. And those are normal findings. Now we got actinic keratosis. And listen, I'm never going to expect you to know what actinic means in Latin, but it looks like acid to me. It sounds like acid to me. So acid skin is not cool, in my opinion. I would be afraid of that. And here's what actinic means. You ready? It means ray. It means to burn. It literally sounds like acid, and it means burn raised area, or solar keratosis, or senile solar keratosis is how it's known. So basically what this means is this is your traditional farmer or your traditional sunbather who loved to tan back in the day and now is too old. And while most of these are a benign process, a small portion of these are malignant. So that would be my answer, just looking at all of these, because varicose veins, normal. Cherry angiomas, I've got some of those. I was born with them. Seborrheic keratosis, sebum area, not really crazy about that. But again, actinic acid ray, that doesn't sound good. So I'm going to go with C, and let's see if we are right. Bum-ba-na-na, Latin is save the day again. So I have decided, after listening to all of you and kind of batting the idea back and forth, that it is worth it, in my opinion, to do maybe a half an hour to an hour long quick Latin review where I explain what these things mean, because the more I explain it, the more you can articulate it in your brain and kind of shelve it in your library of books that goes into your long-term processing of your brain. And hopefully that will give you a little bit of help, because again, sometimes you're not going to know what these disease processes are. I'm never going to expect you to know the 20,000 disease processes, but what I will expect you to know, if you pay attention to this, is what these root words mean, because it is a literal translation in sentence form of what is wrong with your patient, which is kind of cool, to be quite fair. Plus it's the basis of what Italian, Spanish, English, and many other, Portuguese. Yeah, I can go on for a hot minute on these. So I really, really want you to pay attention to that lecture when I do it. I'm probably going to do it sometime the mid next week, to be honest, because well, we need to worry about other things before that. But I think that it would be great for you, especially when we're getting closer to the HESI. We're going to definitely need to know the basic Latin terms. So here is the slide of your assessment for the integumentary system. It's pretty basic. Check the skin. From the second they come in the door, I want you paying attention to their face. See if you see anything that is a spot that's dark, the classic signs of a problem are it's bizarre looking in shape, it's asymmetrical, it's raised. The best way I could do is it looks like a black cloud. So if someone's got a black cloud anywhere in their body when you're doing a skin assessment, it's either a barnacle because it's on their back, or it's melanoma, and it's so far deep that, believe it or not, the spot that you see means that it's penetrated from the inside out, and at that point you're pretty far deep in your stage. So when you find those, that's why it's an emergent assessment, because those guys don't go from the outside in. Those actually develop from the inside and then go through the layers up until it surfaces. Kind of like when you put a seed into the ground. Sorry, I had to think of the English word. When you put a seed into the ground and then it comes up and blooms, that's what these asymmetrical risings, that's how they present. So those are a big deal for that specific reason. So this is a big deal, and this is just for your understanding, and it's also going to be on your test. You need to see when it says subjective data, because they will trick you on these questions. It will say which of these subjective data issues are imperative to the patient's assessment, or something benign like that. And it's going to have 3 objective statements and 1 subjective. So if you see statements like vital signs, heart rate 82, B, respiration rate 12, C, I don't know, blood pressure 120/80, and then D, patient has history and self-reports problems with urinary retention. You're going to know that it's the one that doesn't make sense of the other. So a lot of your testing, when we talk about the HESI breakdown, and I'm going to do a lecture on that too, I'm probably going to do it after our first exam, because I really, really, really want you to pay attention to getting that motivation and getting that confidence and getting through this first exam and doing a good job. And after that, we're going to start really hanging on to cracking the code that is the HESI exam and the questions. So I play the game of one of these things is not like the other. One of these things does not belong, and that's usually your right answer. Because if you calm down, read the question, see what it is they want you to answer, and then look at the answers, you can knock 3 of them off within about 10 seconds just off of basic rationalization and basic pattern sequence. And I'm going to teach you the nerddom that is my brain, that can look into these and usually scratch the answer out with very little effort, because this is how I want you guys to get through this, is with very little effort. So again, subjective data, functional health patterns, health perception. How are you feeling? I feel okay. Or, man, I feel great. Oh, really? Because your heart rate's 160. Probably shouldn't do that cocaine bump that you just did. This happens all the time. Nutritional metabolic patterns. Sometimes there's variance in what they think is a good idea versus not a good idea. So here's a congestive heart failure patient who doesn't like to listen, is very non-compliant, and I'm like, so do you drink a lot? And he's like, no, I don't drink very much. And then I go, okay, well, how much do you drink? And he's like, I don't know, not very much, probably like a 2-liter of soda a day. And then it's everything I can do in my head to go, don't say anything, don't say anything, don't say anything. Keep your mouth shut, Molly, shut up, don't say anything. Elimination pattern, how often do you go to the bathroom? I don't know, 2 or 3 times a day, even though it's like 10 or 12, because they've got issues like diabetes insipidus, and their perception of a lot versus a little is different from ours. Activity, exercise pattern, how often do you exercise? I exercise every day. This is what a nurse says. Hey, nurse, how often do you exercise? I exercise every day. Oh, really? What kind of exercise do you do? I walk back and forth. I did 18,000 steps. I'm sorry, honey bunny. That is not exercise. That is maintenance. That is what your body is maintaining at a regular level. And exercise, I want you to look at exercise as anything above the regulated level at baseline. So if I'm working 3 days a week as a nurse, which I would love to do that. What's that about? People actually work in 3 days, where you walk up and down stairs. After about a month or so, your body gets used to that and plateaus, which is why when you're doing training for, I don't know, a football game, or you're going to be boxing on a different weight class and you got to drop or gain weight and muscle mass, they tell you to switch up your cardio from your legs, from your arms. You'll have a leg day, an arm day, followed by a run day, and then the next week you do it all but an opposite. They do that, and they do these weird drills because it trips your body into starting a new system of weight loss, because your body does get used to these things. So that would not be considered an appropriate quote unquote exercise pattern. Sleep rest pattern, that is different for everybody. Now, the textbook says you need 8 hours. I've never had 8 hours of sleep in my entire life, except for when I had surgery, and then I woke up feeling like I had just been punched in the face, and it wasn't because of the small snippet cut that I had, and the internal structures changed. It was because I physically don't sleep, because that's just how my brain is wired, and that's perfectly fine for me, but it would not be perfectly fine for somebody else, which is why this is subjective and not objective. And then perceptual patterns and cognitive changes, again, I might think to myself, I'm absolutely right, but if your perception is what I'm saying is bollocks and shenanigans, well, then there you go. So here is some more subjective data examples for functional health patterns versus what we did earlier. And these have to do with self-perception, role in relationships, coping, value and belief patterns, and sexuality, reproductive pattern. Now, the perception of self is kind of bizarre, because your perception of self, you could be the most beautiful person in the world and feel like you're the ugliest person in the world. And guess what? You are going to exude unattractiveness and not being self-confident. Studies have statistically shown that men and women prefer confidence over physical beauty and symmetry of the face. Go figure that one. It's because the confidence itself that you have creates a transition of that frequency, energy, and vibrational pattern that transmutes to other people. Long story short, what that means is people who've got mad swag are just more fun to be around, and you find yourself being more attracted to them than maybe somebody who's so pretty and they know it, and they walk around with an attitude on them. All of a sudden, that's not so beautiful, because we all want to be socially accepted, and we also want to have a commonality with people. And if people are brushing you off because they're too busy whipping their hair back and forth, that's a big problem. Roles and relationships also can be askew. Some people could believe that this is my best friend in the whole world, and then we go talk to that best friend, and that best friend's like, I can't stand that person. And you'll see that a lot when you're dealing with patients and their perception of their relationships when we're talking about depressive episodes. Sexuality and reproductive patterns. Some people believe that they can't get pregnant. When they go into an OBGYN, they're going to seek help, and they say, hey, I'm just not doing the things to be able to get pregnant. I've been trying for a year, and they've stressed themselves out to the point of not being able to relax enough for their body to do what it needs to do. So they talk about subjectiveness with reproductive patterns, because a lot of times their subjective approach and thought process dictates their body to send that brain to body message to activate what it needs to activate to start that cycle of reproduction. Coping and stress tolerance patterns, again, that's absolutely subjective, because, in my brain, taking a test doesn't stress me out. I say that, and right now I feel 20 people wanting to throw daggers at me. It's cool. I get it. Right? Just make sure that you understand what the difference is, because it's going to tell you functional health patterns with subjective data in a patient recalls what type of information. And it's a weird way of asking, give me the subjective answer. And again, all the other ones are going to be objective, or, the opposite to the situation. Okay, so objective data obviously is the opposite. These are the absolutes. These are numbers. These are lesions that have sizes and depth. These are secondary skin lesions. These are systemic general inspections. Or systematic general inspections. So when we're doing a physical examination with objective data, we want to be really careful not to throw any subjective data in there because it's easy to say looks like, right? And if I say looks like, then that is my subjective perception of what my eyes, my rods, and my cones are perceiving through my brain, which is not an absolute. But what is an absolute is size, depth, pattern, symmetry or asymmetry, right? So we need to make sure that we are putting these in the appropriate area. Um, uh, Long story short, I had a problem with subjective and objective, which is why I'm hitting hard on this in my nursing career starting off. I don't know why I couldn't get subjective versus objective. It sounds so silly. So when I would do my concept mapping, we would have to put in subjective versus objective data, and I nearly got kicked out of nursing school and failed out because of these two simple concepts, which I obviously now get, but at the time I couldn't put it together for some dumb reason. So just make sure that you understand if it's an absolute that isn't going to change, like a number or a value, those are going to go in objective, and subjective is whatever Bobby Sue's cousins, uncles, baby mama said, right? So we'll move on to the next slide because I think you guys got that. So make sure that you are in your physical examination talking about inspection of the skin, the hair, and the nails. These are pretty important because a lot of times, especially with skin, we're going to find these patterns. Hair, sometimes we might have alopecia and we'll see, a patch, but that alopecia patch might actually not be alopecia. It might be a ringworm, right? Little kids get that in their hair and they lose a patch of hair just like you would with someone who has alopecia. So make sure that you are clearly defining things that would separate one from the other. So here's a prime example. Objective data for presentation of alopecia. Hair is not present in the area, nor are fine hairs or baby hairs, versus hair is missing an area in small clusters around line of demarcation of a raised circle, 3 centimeters by 2 centimeters by 1 centimeter. That's kind of how that goes. So again, physical examination, I feel like we've been talking about these for a while. Temperature, turgor, moisture, texture, all the things. Just make sure that you've got that clearly understood. And it sounds like you guys have, just talking with you personally. So I'm not really going to touch much on this one. Okay, so primary skin lesions, there's a handful of them. There's like bulliae, there's pustules, there's papules, there's plaques, there's nodules, let's see, tumors, wheals, and I don't mean the four that go in your car, macules, patches. Ooh, I think that's it. So, really quick, bulliae, which is Bullae, those are vesicles that are larger than a half a centimeter in diameter. They rupture easy because they have really, really thin cell walls. So like large blisters from a second degree burn would be a classification for a bulliae so that you understand what that looks like. A pustule is something that's similar to a vesicle, but it's filled with the purulent drainage rather than the serous fluid. So rather than that clear business, it's kind of that pussy. We learned that word earlier, didn't we? That darkened color that's that white, that green, that yellowish kind of tinge. Acne, impetigo, all these things cause those pustules. Papules, they're elevated, they're circumscribed, they're firm lesions, and they're about half a centimeter or up to half a centimeter in diameter. So let's see, warts, in drug-related eruptions from not anaphylaxis necessarily, but from allergic reaction. Those are classified as papules. You'll have papules when you get onto the sun too much and you get that neck area that's papular and red, and you'll get them on your face as well, and we'll know to put sunscreen on that. We're going to get into that again with your second lecture, but I think I did mention neck and facial papules that are red and itchy, specific to our test review. So I would just know that those things are indicative of more than likely a sunburn from skin exposure to the rays, and a good way to fix that problem is to tell them, hey dummy, wear sunscreen. Okay. Nodules, they measure less than a half a centimeter in diameter. They're similar to papules, but they tend to be deeper in the dermis and they feel firmer. So they're a lot thicker and more, what's the word I'm looking for here? You know how you bite into something and it's really, really chewy? It's kind of like, it feels like that, kind of trying to squish it. Classic types of nodules are fibromas and intradermal, like nevi. Also, you'll see nodules when you are looking at an X-ray. They'll find like an incidental nodule that usually doesn't mean anything, but usually is in the lower lobe of the lung. Tumors, obviously, those are larger nodules. Those are over a half a centimeter on the surface and extend deeper into the dermis than the nodules. They may or may not be clearly demarcated, which means they might not have a perfect little shape of origin. They could be firm or soft, and they could be benign or malignant. So we need to, whenever we find an actual tumor or a nodule that's gotten bigger than that and transitioned into a tumor, we obviously have to do a biopsy for those. Now, wheals. I made a joke about cars, but I'm dead serious. It's WHEALS. It varies in size and shape. Those areas of edema are elevated, irregular. They're relatively transient. A mosquito bite causes a wheal, right? Urticaria or urticaria, I say urticaria, is a hive. There's multiple wheals that are usually caused by severe itching from a hypersensitive reaction. So keep that in mind. Macules are flat. They are non-palpable. They're less than a half a centimeter in diameter. They are circumscribed and may be brown. They could be red. I've seen them white. I've seen them tan. They can be present in conditions like rubella or flat moles, freckles, things of that nature. And then patches, they're different from macules in that they're very irregular in shape. They measure more than a half a centimeter in diameter. Vitiligo, port wine marks are classic examples of what you would call a patch. And vitiligo or a port wine is really not that big of a deal. It's an incidental transition of the skin while it was being constructed in neogenesis. Okay, secondary skin lesions. This is where it gets a little bit hairy. So a secondary skin lesion is a result of a primary skin lesion that has been modified, usually because of manual transcription into another phase. That sounds really confusing. Let me help you out here. So, prime example, I get a mosquito bite, I get a wheal because that's considered a wheal. A WHEAL. So I get a mosquito bite, and what do? Because it itches, you scratch it. All right, cool. So now I have a secondary skin issue. So this is the result of scratching, itching, pinching, putting a chemical on it that's going to cause it to raise its skin or ulcerate. And there's 7 of them. So you've got scales, you've got crust, you've got excoriation, you've got erosion, you've got ulcer, and you've got fissures. So how can I do this easy? Scales are a loose surface of epithelium. So from dry skin, you get scaly, all right? Crust is a dried surface fluid, so like impetigo is a good example. Another one is shingles, because those have crusts. We need to wash those with soap and water, FYI, soap and water. And if I do recall, I believe I said something about that in the test review. Soap and water when you're dealing with impetigo crusts, or when you're dealing with herpes zoster secondary infections like shingles. Scratches are going to be your excoriations. Erosions are superficial, superficial lesions, we'll just say that. Erosion of the tissue is going to be an ulcer, and linear skin cracks are going to be fissures. And those, I say linear because they absolutely look like long lines of a crack in the skin. A good example of a fissure would be old ladies that don't put lotion on their heels over, a period of 30 years. They have those cracks in the heel of their foot that just look really, really gnarly. That would be an example of a fissure. Okay, this one just tells you to look at section 22.7 of the lesions and the terminology in the textbook. You're going to see different ones, I'm sure, than the ones I just talked about. So just give it a little look-see and walk over it. Okay, so let's go ahead and break this question down and hack through it, okay? When documenting normal findings of an assessment of the patient's skin, which entry by the nurse is most appropriate? So what did the nurse say that didn't look stupid, okay, is the best way to break this one down. So skin warm and dry, I'm cool with that. Turgor good, what the heck does that mean? Nails flat and pink, okay. Old surgical scars noted on the abdomen. Okay. What type of surgical scar? How big is it? Is it raised? Is it recessed? Huh? So I'm going to say that's a no-no. B, history of allergic rashes. Okay, history, cool, but not present, so that's bizarre. All right. Skin very fair. Very fair. All right, cool. What's your perception of fair? With numerous freckles. All right, cool. Define what numerous is. Numerous could be 10 or numerous can be 1,000. Warm and intact, no lesions noted. Okay, that's better, but still, we're missing a lot, so I'm not a fan of that one. Skin brown, cool. Slightly moist and warm, cool. Turgor immediate return. Love that. No lesions noted. Awesome. States no problems with skin. I'm down with that. That's my happiest one so far. Let's look at D. No history of skin problems. Okay. Skin intact. Cool. Pink. All right. Temperature cooler in extremities. Okay. Define cooler, right? Are we like burning hot on the inside? Because that could be a problem. Is this like Raynaud's? Do we have frostbite? Like define cooler. What color is it anyways? Is it blue? Is it white? What's happening here? No lesions except numerous brown moles. All right, cool. Numerous brown moles. Got it. So that doesn't tell me anything. So I'm going to say by default that my answer is C. So let's check. Hey, guess what? We did it. So again, skin brown, got my color, perfect. Slightly moist and warm. I understand what slightly moist and warm means in my brain. Turgor immediate return. That's my trigger right there. Because when we're talking about skin turgor, we want to know if it is a sluggish return or if it's an immediate return. So just by seeing that alone, that was enough. And if you notice, and this is just me getting weird and doing the pattern thing that I do with, my disease process. Skin warm, comma, slightly moist and brown, comma. If you notice right square in the middle of that entire assessment, the biggest trigger is squat in the middle, right? Because after that is no lesions noted, comma, states no problem with skin, period. All right. Usually you're going to see this in a test. Your test is normally going to show you your immediate midline field of gaze. And I know that sounds really bizarre, but literally get into the psychosomatics of how we do testing nowadays. We literally want you to be able to look at the test, square into the middle of it, which is turgor immediate return, and put your trigger sentence in there to denote that that is your answer. And I will explain that when we get into the schematics of, the psychology behind test taking and what that means for you and trying to find the right answer, regardless of whether you know the answer or not. That's the beauty of the system. Okay, we'll get into it later after we get through this first test. But just know, turgor immediate return is a trigger sentence to let me know that is exactly what I'm looking for, and that's our right answer. So keloids. Keloids are striated tissue that changes and manipulates its cell structure because basically it gets ticked off. This is usually trauma related, and this is usually related to ear piercings using a gun versus boring a hole through. It pushes the skin out, and as it does that, it causes an inflammatory response, which then triggers the change and manipulation and malleability of that cell structure to get this nice little nasty scar that you have in the back. You'll notice that this keloid is not in the front because literally this came from a person that just hit that gun, just boop, and then the tissue got really ticked off, to be fair. You'll also see this in boxing. People have keloids or what they call a cauliflower ear. That's usually because they get cracked in the head. It usually is on their left ear because usually your boxer's a righty. He rabbit punches you into the ear. You get that big purplish nastiness, and it needs immediately lanced. I have my left ear, I've had it lanced 4 or 5 times that I can think of right off bat, and usually they have an X-Acto knife when you are in a boxing ring, or they usually just keep them in their pocket so that they can just, rub alcohol, slice, and then you can get back to work. I know that sounds so weird, but just remember keloids. You won't forget it after this. A lot of people have it post-surgery. These guys have to be lasered off. These guys have to be cut off. And these are now treatments that you can opt for when you go to dermatology if they do bother you. Other than that, they're just a nuisance to look at, but they really don't cause any other issue long term. I'm pretty sure that that's accurate. I don't recall anything that it can cause a problem with. Oh yeah, I can, because when we were going over our review, we went over keloids, and sometimes it can be in a really poor location, like in your neck, and it will literally push everything when you're trying to lay on it, and that can be incredibly uncomfortable. So sometimes you have to do elective cosmetic procedures to get rid of these guys, just because it does produce pain. All right, ladies and gentlemen and non-binary friends, so here's the deal. I'm going to introduce you to the most cold-blooded killer in the history of all time. And the reason that the Aries zodiac is known as being an arrogant jerk who just wants to pillage and beat people to death and kill everything, because it's not actually what we are. Not entirely. That's not a thing, I promise. However, this is the reason why we get this bad rap. Because this guy, this is Genghis Khan. Genghis Khan is the most cold-blooded killer in history. If you can find somebody who was worse than him, let me know. I cannot wait to read up on him. Because here's the deal. I've read this guy's works. This guy thought he was a deity. He thought he was a deity because of the Mongolian blue spots. He had a genetic trait that gave him these. Now, what is a Mongolian blue spot? A Mongolian blue spot is this. It is a baby who is born who has these blue pigmentations. It's benign. It doesn't hurt anybody. What happened is the melanin just stayed at the bottom of the tissue surface rather than rising to the top like it was supposed to. So it creates this, cafe au lait like spot, only it is blue. Sometimes it's turquoise. Sometimes it's a really nice turquoise. Sometimes it's a really light turquoise, right? So why then was this person able to kill? You ready for this? Everyone's like, Hitler's the worst. No, he wasn't. I think he killed 6 million people. This guy killed 40 million people. Yikes. Not only was that a big deal, but he also would, how do I do this? Well, I'm just going to have to do it because we have to talk about these things. He would rape and pillage. And when I say he would rape and pillage, I mean down to the last person. So what he would do is he would go into battle, and he went into every battle. He wouldn't just stand in a tent. He'd go into every battle. He would then cut off the hands of all of the people. He would cut the left hand off. And then he would throw them in a pile. He'd get all of his boys to throw them in a pile. So some of these piles were, 10, 20, 30, 40 feet, right? And then he would go into town, grab the ladies, take them back to the hands, and then impregnate them. Like I said, this guy's a cold-blooded killer. I read up a lot on this guy. I don't read about his history. I read his work. Like, he thought he was a literal deity. He thought he was God coming down from heaven. And this is a problem, is we get a lot of these people that think that they're a piece of God coming down from heaven. I'm here to tell you, we're all a piece of God. We're all a piece of God. Read your Bible. Read your Torah. Read your Tanakh. Right? Read your Quran. It's in there. We are of his essence. Therefore, we are him. Just like my blood courses through your veins, because at one point we had 1,240 people living on this planet. And those 3 generations, or 12 houses, if you do the division, I've done it. If you do the math that we did in class that one day, we will know that civilization was created at one point, and it laid in the balance of 12 people, 12 houses, 12 divisions, 12 tribes, however you want to put it. Does that sound familiar to you guys? It should. Because whatever collective work that you read, that you believe is your personal creator, right? And I'm totally cool with, by the way, tell him I said hi from my creator, because that's awesome. Those are always the storylines, or a derivative of that's very closely related. Why do you think that is, guys? Why do you think that is? This guy thought he was a piece of that, and he killed 40 million people trying to prove it. 40 million people died because he thought he was a deity. This is why power is a problem. This is why power is a problem. I've got the blue spots. Am I a deity? No, I'm autistic. Should we call that deities? Well, back in the day, they thought it was. Now we just know it's just basic human evolution. I just got there first. You're coming. Your generations are coming. Your children are coming. I just got here first. That's it. There's no difference. As we evolve, we find things that we need to create more evolution, because that is the natural properties of this law of Earth, right? Basically, there's a lot of pathophysiology and a lot of connectivity with geometry and things of that nature and physics, but I'm not going to get into it right now. There's no sense in it. What I will tell you is you need to know that this spot is because of this one dude, period. We got it. We have brought it back to a genetic tie. So that is what you can create. And this guy, let's see, he was born in 1227. 1227's popping in my head. April of 1227. I know that because he's a freaking Aries and so am I. So growing up, I would read about this guy at the library, right? When I would, walk 4 miles to the library and sneak in there. I'd read about this guy. And I'd read about his thoughts. He used to creep me out really bad for obvious reasons. He did a lot of terrible things. I'm not going to read about him if you want to. But the lesson in this slide is thus. I don't care what you are that makes you special. Don't ever let it be so special that you forget your humanity within you. I don't care if Genghis Khan was a deity. He could have been. I mean, come on, let's face it. Nobody knows what we're doing here. We put a lot of things together and they all stack up together and they all correlate together and the numbers crunch. But you roll your eyes and go, how is that even a thing? I have no idea, right? We don't know. But there's something there that makes us feel like we have a purpose. There's a drive throughout times and ages that will make us do crazy things. Let me do some quick math. 796 years later, this man's butchery courses through my veins. That is what I mean by making ripples in history that change the course of human existence. With this also comes a potentiation for getting those awful memories that he had, all of those repressive thoughts, all of that, I've got to be in control and power because I am super, super self-deprecating on the inside and I've got to fill it with some type of void. All of those things potentiate and carry, those genetic memories carry from generation to generation. Why do you think I stand so hard on being so hard? Why do you think me being the captain of the ship means so much to me and it courses through my veins so hard that it becomes a part of my essence? For all I know, it might be because I hold this crazy person's genetic cycle. However, I use that drive that he may have had, that he may have passed on to me. I use that as a motivator, not a destroyer. So we all have a choice. We all have a choice, and part of that choice that you make consciously is making sure that we have the knowledge behind the choice and making sure that knowledge is accurate. I submit to you, if you have these people as your patients who may have had this spot but have remained with this spot throughout adulthood, you will notice that this patient has 20 people around them at all times. So if you hurt that patient, if you upset that patient, you have effectively made all 20 of those people in that room mad. These people will die for this person because they believe that they are a deity, much like Genghis Khan believed that he was a deity. I don't believe I'm a deity. I believe I got blue marks all over the place and I have autism. And that makes me different. And I can see where they would think that that would be of the heavens. But remember, deities aren't all good either. Deities are bad. This is a good example of one. So find your house, find the side you lie on, stay there, and if you are a friend, welcome to the family. I will be your captain until the day I die. I will go into battle with you And I will fight with you and I will die with you because that is what I am on the inside. And if you were a foe, good luck because my legion is behind me and we're going to get you. So come at us because we ain't afraid. And that's the kind of mentality you need to take. Have respect. Let them slap you on the face. Let them, so that you can see what kind of integrity they truly have. But back off and wait. And if they attack you again, friends, you know my number. It's on speed dial. I got you. Because I dare somebody to hurt my family. That's how deep this runs. Just like this Mongolian blue spot. All right? So be mindful of the things that you create around you. The ripples that you create, it stands the test of time, friends. It stands the test of time. And that's all there is to it. So next slide. Okay, vitiligo. Vitiligo occurs when the cells that produce the melanin, they die or they stop functioning. It affects people of all skin types, honestly, but it's more noticeable in people with brown or black skin. It's not life-threatening. It's also not contagious. A lot of times it's genetic in propensity. It can be stressful. It can make you feel bad about yourself. Me personally, I think it's beautiful. I think it's absolutely gorgeous because not only is it different and I cannot stand for everything else to be the same. It's like eating the same thing every day. You would never do that because it's just a misery and boring. So these skin conditions, to me, it bothers a lot of people. They feel bad about themselves. They get made fun of, all of the terrible things. But to me, it's just a unique representation of what we all really are on the inside, which is the same type of person that is capable of the same, hypothelial tissue. And it just lets us know that, we're all connected and we're really not that different after all. So this is beautiful to me. We have models that have vitiligo. I know that Michael Jackson is the constant topic when we talk about vitiligo. Vitiligo, like I said, is not contagious. It is nothing to be afraid of. However, what is trying to bleach the rest of your skin. That is a problem. So I would encourage you, don't be so stressed out if you do see a change in skin discoloration, if there's patches everywhere, if you have darker skin. I would, make sure that there's nothing wrong with it, but it usually happens pretty young, and then as you get older, those patches change their line of demarcation and they stretch out a little bit, but other than that, they're pretty benign. So traction alopecia. Traction alopecia is different from genetic alopecia. Sorry, I had to drink some water. So traction alopecia happens a lot in females, or gentlemen with long hair. So traction, what does traction mean? It means we're walking over something, basically. So in this case, we put our hair up in a bun as females. We get weaves, we get tape-ins, we get sew-ins, we get microbeads that are weaved in as well. And what it does is it puts traction on the top root of our hair. So what happens is as we pull these tracks off and we, transition those tape-ins up, or we, undo all of those braids and do a rebraid. Those braids are super duper tight, especially when you're trying to have a traditional micro braid put in. It's very painful. You see little kids in elementary school that have the most beautiful hair that is literally in swirls, and there are beautiful beads at the bottom. When they turn their hair side to side, it makes a gorgeous sound. But those kids are always, if you recall in school, they're always tapping their head. They're always grabbing a pencil and scratching in between the crevices, because what they don't understand is they're getting traction alopecia, and this makes the hair break off at the very, very top, and you literally lose entire clumps of hair sometimes. So you need to make sure, if you are a female or a male with longer hair, you need to stop putting it up in a tight bun. You don't want to sleep in a tight bun. People do that and think, oh, my hair is going to grow. No, dog, you're actually going to be killing that shaft. So you got to really, really be careful of that. I have always done a tight bun, and after having babies, things change. And one of the things that changed with me is I started to lose some hair, and that's perfectly normal. But the problem with that is I was trying to grow it by putting it in these really tight braids, and realized that, it just made it worse. So traction alopecia, again, this is something that we can prevent. Does the hair grow back? Sometimes yes, sometimes no. Sometimes that traction alopecia scars the tissue at the scalp and it does not come back. So you just got to be really careful. Make sure that you understand traction alopecia is different. It's self-induced. It's something that can be preventable. There's a lot of tension. You're going to get headaches. You're going to get it often, and eventually you're going to lose that hair from, a permanent standpoint. All right, so we have to do an inspection and a history to find out what's going on when we see something that is not regular. So if we see something that has asymmetry, that's darkened, that's raised, we're concerned with, the melanoma, we're concerned with other issues. Sometimes we have to do a scraping. Sometimes we have to do a punch, where we literally punch that entire area out and send it out for biopsy. Sometimes we have to do a stain on it, so we'll do a cell scraping, and then we'll put it under a microscope with a green stain, a blue stain, a gram stain. You guys remember those things, I'm hoping, back in microbiology. Immunofluorescence is basically the same concept except for using light. Curettage, I honestly I don't think I've heard of that one before, so give me just a second to Google it, because I am blown on that one, which doesn't happen very often, so this will be fun for me. Curettage. It is medical procedure used a curette to remove tissue by scraping or scooping. Oh, that is a punch. Okay, so that's what they call it. So a curettage is an actual curette, which is a tool that we use in ENT, where we have a little scoop at the end of a metal tool. We usually use it to scrape out someone who has impacted cerumen or impacted wax, and it literally scoops it out. And some of these have tiny little razors where we could do the same and get a scraping off of it, but it's a little bit more in depth. So that's what that is, and I'm glad I know it now. And finally, this is your diagnostic study for a skin test. So an allergy test or a patch test is where you have a track of 15 plastic needles. I did say plastic needles, and they're very, very, very sharp at the tip. It's not meant to be a complete puncture. Most people say, oh, I had to get individual, 15 or 20 different rows, 200 different spots where they just injected needles into me. It doesn't quite work that way anymore. So it used to be that way, and we used to use insulin syringes because they were super tiny, like the size of a hair, and you didn't really feel it. It was the allergen that made it tough, and the fact that somebody was poking you with a needle that would scare the dickens out of you. Nowadays, especially with kids, we want to do it as non-disruptive as possible, right? So what you do is you open up all of your vials that are in a certain type of row. It comes in a luggage pack. So you open up your luggage pack, you take all your tops off, and you have these plastic cones that have sharp tips that are just enough to penetrate a pop into the skin. So if I put my nail down and dig my nail down, that's what it feels like. So dig your nail in the skin, and that's all that there is to it. And you literally dip it in, and you pull it up, you let a couple of drops fly off of it, and you go, all right, cool, that's taut, that's good enough. And you literally walk it over the patient on a dermatome. So you usually do it in these areas, and this is a little more complex because they're trying to show you what it looks like from a perfect perspective, but usually you just walk it over, you put a 1, walk it over, put a 2, and that whole line of 1 and 2, all you have to do is just correlate it back to find out what it was that was the contaminant that you introduced to the skin, to find out if it was a hot spot for the patient or not. And you can see where it is hot because you have these wheals, WHEALS, that show that raised reaction. And that is it for this. We're going to go do chapter 23 next.